And welcome once again to Profiles. I'm Ed Hyland. Today we ask the question, what would you do if you couldn't communicate? It's a question that confronts people with conditions like Parkinson's every day. Jane Hostetler is a clinical instructor with the Communications Disorders Clinic at UCF Research Park. Jane, thank you so much for coming by and joining us today. Tell us a little bit first about the clinic and how it operates.
Well, the clinic is basically run by a set of clinical instructors who take on students. Mainly in our department, we have grad students that are actually seeing patients. The patients are usually referred through the community, and then we evaluate them and then treat them and assign students to the cases.
Well, one of the things that was just fascinating when I had a chance to go over there is the work with some of the patients, in particular a Parkinson's patient who we'll meet in just a couple of minutes. But first, as kind of a setup, let's talk a little bit about the Silverman Technique. Explain the full run of how that works and kind of how it came about and why you're utilizing it.
Well, actually, it was in I believe it was 86, that there was a speech pathologist by the name of Lori Remig who was working with a wonderful lady by the name of Lee Silverman who had Parkinson's disease. And the family had stated that, oh, if we could just only hear and understand her speech. And from that premise, she just sort of took it running to develop this program, and soon formed was the Lee Silverman Voice Training Foundation, and that's how the program began.
Let's talk a little bit about Parkinson's as a condition. We have seen high-profile people, Michael J. Fox, Muhammad Ali, individuals who do have Parkinson, and you are fairly familiar with the involuntary muscle movement, the jerkiness that occurs there. But you don't think about, I guess, so much as what happens until you try and hear an individual with Parkinson's speak. The muscle tone, it just starts to fade. It goes away, and it makes it very difficult for them to communicate. Yet the mind is sharp. The mind is there.
Oh, absolutely, and that's. I know we've had patients at times have just said that I feel trapped inside my body, and you're correct that the cognition is usually there. Sometimes it can be somewhat diminished, but with Parkinson's, basically your patients can show signs of rigidity or actually difficulty initiating movement, which is so frustrating, and especially in our patient that we're going to talk about today. And then the masked facial expression, a lot of times that these people will just have facial expressions that actually show no expression at all, and although that they're feeling things, it's not real evident to be looking at them. They don't show that emotion on their faces. And in a lot of times too, that the medications also interfere with, they have a choice of either are they able to initiate movement and move, or are they going to take their medications? So, again, in our patient's case, when she has difficulty actually getting started, she can't initiate the movements, or they're very slow and labored, then she has to take her medication. And then the medication can have side effects, of which she has extra extraneous movements, and then you get into some of the jerky type behaviors and
yeah, it's just a catch-22 for them.
Absolutely.
As far as trying to medicate or not medicate, and communicate or not communicate, I guess, in some instances. And I guess as we've seen with the muscles being involuntary, that the throat, the muscles, the tongue, the lips, all of those would also be affected in a similar fashion.
Absolutely. Well, what happens too is that respiration is affected. There's that rigidity, so you don't have a lot of the breath support to have them voice in an adequate manner, and so therefore when they try to speak, it's usually very diminished or can become very diminished. And then there are other times during the day it may be a little better depending on where they are with their medication routine. But it's very frustrating because not only does it begin to affect the voice, but then sometimes there are rushes of speech that occur where their words just jam together real quickly, and that also reduces the intelligibility, and then through all of it, the articulation is affected.
Well, it would be incredibly difficult, I would think. You can't read the face, and sometimes in communications that's very important. If they can't get the words out, they can't even write a note to express what they're feeling or what they need. And so again, that catch-22 kind of comes to haunt them. Let's take a look at some of the video. We have to thank our friend Glenda, who was kind enough to let us in on a therapy session. We're going to kind of break this up in a couple of different parts so we can show you a representative example of exactly what goes on in a therapy session at the Communications Disorders Clinic. And I guess, just coming on into the center, we have Glenda and your clinical. Why don't you introduce everyone to us first?
Okay, well, Glenda is our patient, and then we have Kia and Jennifer, who are the two student clinicians. They're graduate students and have just been absolutely wonderful.
And there's the
with
key
her.
phrase right there. They're great and think loud. I mean, almost from the time you walk in, they're yelling at each other. What's going on here?
Well, that is basically the premise of the entire program. It sounds like it should be something that is extremely simple, but as you can see, they're doing many things. They're metering what she is doing. They're trying to get her to over-exercise the system, the voicing system, and they have to meter that and at the same time try to get her to do it. And all of that, it takes a lot of skill. And so what we're trying to do here, and what you're seeing here at this moment, is some of the dyskinesias that she has. Again, the medications, she'll tell us that it gets worse with the medications, but her choice is, do I want to talk today or do I want to move?
When they're relearning, I guess would be the best way to put it, relearning how to speak, not only is it, I think, physically demanding, or does it seem to be physically demanding because their muscles are kind of out of control, but the projection, they have to think loud. They've got to put the extra effort into it. It's got to be very physically demanding to go through a therapy session like this, and also remember to do this when you're out and about in the public so you can make your message understood.
Right. And I think that's probably, for me as a speech pathologist, one of the most difficult things that I have doing is because it is kind of a relentless therapy. The whole idea is that you want to overstimulate that system, and then in overstimulating it, some of the subsystems kick in, such as the articulation will be somewhat improved, and the rate of speech automatically slows down with the loudness. And in order to overstimulate the system, normally in traditional therapies, we're always so concerned of that fatigue factor with our patients, and we do have rest periods, but not in this therapy. In this therapy, you ask them, of course you don't want any pain and you don't want any discomfort, but you ask them, are you feeling tired? And they'll tell you yes, and we'll say, good, then that means you're really working the system out well, and then you push them further. So this goes on the entire hour long, that we're pushing it to that capacity so that, again, we have overstimulated the system.
Now it's a 1-hour session. How often?
It is a very intense program. That's another component, I think, that makes this so successful, is that we have our patients come in 4 days a week, and it's for 4 weeks. It can extend further than that if needed, but that's the minimum of the program. And it takes a commitment on the patient's part too. That's a lot of time for a patient and their families to be coming out to the clinic. So it definitely is commitment on their part.
And they've got homework too. I know Glenda had some phone calls, as I recall, to make.
Absolutely. So what we do is we give them homework to do, where she'll basically go home and she'll practice the first part of the therapy session that we do every day with her, and she's to do that once a day. Now, and when weekends come, no, we don't let them rest then either. So they have to continue with it and actually do it twice a day during the weekends. And then hopefully when this is completed, this will continue to be their regime. It's similar to an athlete. When you have an athlete who's training and they finish their race, they don't quit training at that point. If you still want to keep in shape and make those muscles work, you continue the training.
Yeah, that kept coming to my mind. It's like an athlete or someone who's exercising a muscle or muscle group. Is you keep working on it, you build up the stamina. 4 days a week plus homework, 4 weeks, an intensive session there. But how long does it last? Do they have to come in for tune-ups after that point in time? How much will the therapy help them, or for how long?
Sure. Well, what we'd like to do is to have them come back at 6-month intervals first, just to do a check and to see how they're doing, and if we need to do a booster shot, so to speak, just to get them back on track with it again, that can be applied at that time. research has shown that sometimes the effects of it will last out to 2 years, which that's pretty awesome.
Now, are we doing some research also? I mean, obviously this is a technique which is being utilized here, but are we still in the experimental stage, for lack of a better term, in terms of trying to find other ways that will, stretch out the time frame, maybe increase its effectiveness? Are we still learning as we help patients like Glenda?
I think that that's true. I know with the LSVT Foundation, I know they continue their research. I think some of the other areas that they're looking into is, does this work for any other disorder besides the Parkinson's? And some of the early research is showing that with head injury, TBI, or strokes, they're trying some of it with dysarthria type patients, that they are seeing some progress with that, and they are showing some significant gains.
Yeah, it must
from
work
it.
some parts of the brain. The layperson would say, well, there's something done right here. Maybe
Yeah.
it will help in other areas.
Yeah.
Let's go back and look at a little more of the video, because we're talking about just how intensive it's training. I mean, it's not just therapy. It is a training program to try and get folks to relearn how to speak. We're again showing some of the. And she stood the whole time. That whole hour she was standing there.
Now this is also was very interesting to us because we weren't really expecting this. Our equipment, we had geared down into a small little tripod, but found that when she sat, she began to have so much movement that she couldn't manage. And so therefore we had to change the equipment and put it higher so she could stand, and then we were able to conduct the program.
And while speaking is a part of it, I noticed the initial stages were hitting tones and seeing how long you could keep that tone going. What's the purpose there? She's doing scales now.
Well, first of all, when we start out, we try to get on what we call a target voice. We don't want it strained or scratchy or painful, or what we call a hyperfunction. But what we're trying to do is to get a good solid tone, and once they've established that, we want to draw it out as long as we can, and so they're timed with that. But at the same time, we're also looking at the sound pressure meter to make sure that they're hitting certain decibels, and that's how we can see some of the progress. Then we move to the tones, where we go from the highs to the lows and lows to the highs. And what we're doing there is we're exercising the systems, the muscles. We're not necessarily looking for them to become an opera singer. We don't calibrate them against other people. They simply are you're judging the gains against themselves. So if you have a patient who only makes a small increment, like maybe a note, then in that aspect they've done great. They've made some change, and in Glenda's case, she's just, she's done so well with it.
And she had, as I understand, at one time she was a little country band, so
Yes.
singing comes naturally to her. It's something she enjoys doing, and of course it's so much easier as a therapist when you have someone who is enjoying the therapy.
That's right, and she was so cute because so many times as we would do this particular task with her, she didn't like the quality of her voice at a certain level because it was either too high or out of her singing range. But she still continued to really make gains.
That's fascinating stuff. And as it progresses, as she comes back, you see the taking of the notes and such. How do you gauge? I mean, obviously you can hear when a person is speaking more clearly, but over the course of 4 weeks, how do you gauge the little steps, the little bits of progress that are made? We see little notes and numbers. What do those mean?
Well, and I think again that this is another really tremendous aspect of this therapy, is that it is very accountable, because what you're doing during the entire session is you'll watch Kia and Jennifer. They're watching the sound pressure level meter, and they're continuing to write what that meter is showing, and it continues to change all throughout her exercises, and the same with the meter that's showing what the pitches are.
Yeah.
So in that aspect, always to go through and to keep that type of data, and then to be able to compare it from the beginning to the end, I think is really, it shows exactly what this program does. It's not, where you're just looking at it and making subjective
but she was involved too, because they were asking at the end of a session, they'd say, well, how did you rate yourself today? How would you rate, your performance on that one? And you kind of think back, well, when I'm rating myself on something, I'll either give myself an artificially low number or artificially high, one or the other. How does that help, having the patients involved that way?
And again, I think that this is another aspect of this therapy that has just made it is so important. That aspect of it is called calibration. And what that means is that we want to know whether that patient is really seeing the difference in their speech. Now, what will happen many times is you'll get a patient in therapy, they'll do beautifully and they'll judge themselves, oh, I did a 10 on that, or I've done an 8 on 1 to 10. What do you think you've done? And they will do beautifully and just look gorgeous through the therapy, and they walk out of the therapy door and then back down to the diminished aspect of the speech again. So at that point, they are not calibrated. They have not been able to judge their effort in relationship to how much better they can make their voice.
Sure.
So that's why we really drill it. It's so important that we know that that patient really sees the purpose and the gain in what they're doing. And so we have to calibrate them. And so we ask her to participate. What did you think of that? Well, I think it was a lot better, so that they sell themselves on the idea.
Is this therapy ever used in conjunction with other forms of therapy? And I'm thinking physical therapy comes to mind. Is it ever done at the same time? And then also, I guess there would be the for lack of a better term, the mental therapy. I mean, here's someone who potentially would have confidence issues and self-image issues. Is it ever worked in conjunction with that to kind of build the entire patient at the same time?
Well, I think I can't really speak on physical therapy. I'm not really sure of that, but I think that when we're treating that person, we're treating the whole person. We don't want them just to be able to voice adequately and then send them off on their way. We want the whole point of the program is to empower the patient, and that's one of the key issues with it. Is we want to empower them to get back into the swing of life again, so that they can speak again and they can order at a restaurant, or they can talk to their daughter or their son on the telephone and be heard and understood. So because unfortunately, when the speech diminishes, people tend to withdraw and isolate themselves. And so hopefully in that aspect, we are working the whole patient.
Well, fortunately in Glenda, you have a very outgoing person who I suspect was probably that way even before the therapy began.
I think so.
One of the things in the last bit of the tape that I wanted to show and have you tell us a little bit about was the phrases. And as you're watching it, you really are impacted by it, because we talked about tones before. There was a steady tone, and then there was the range of tones, which you've described as being a way to build up the muscle and build up the confidence level. And then in the last portion of it, it was actually working on some phrases. And again, the think loud part of it was all very important. Again, here's some of the note taking. But give us an idea of there's a series of phrases that she was reading there that she, I guess, helped develop actually.
That's right. She comes up with 10 functional phrases. And these are things that we don't want to come up with for her. She is to invite us into her environment and come up with things that she will use at home, or that she may say at home and maybe will not be understood. And in Glenda's case, she drills through those 10 phrases, and one of them we just always got so tickled with was she would say, "Chico, get off the couch." And at first we were wondering who Chico was. Well, Chico is her cat. So that's important for her to tell the cat to get off the couch. So anyway, she devises those phrases, and then she will practice them not only in our sessions and in her sessions that she does at home, her homework, but she will continue with that. And therefore, hopefully the carryover of that will be great, and she will be able to utilize that into her home environment.
Yeah, there was the get off the couch. I was trying to remember some of the others, but there's something about a potted plant, get the plants, I think was another one. But it was a little key into her life and the way it works right now, because each of these phrases, and it's just a couple words.
That's
but
right.
What was important is not only the words, but how they were said and how loud they were said.
That's right, and I think one of the phrases that it really gives us a little insight into her life is that she'll say, "I'm turned off" or "I'm turned on," and what that means is that with her medications or with the Parkinson's, either she's on and she can move and she can do, or else everything has shut down, she's off. So
and that can be very important for caregivers
Yeah.
and family members to know exactly what her status is physically and mentally at that time.
That's right, because if you don't get the facial expressions from that person to really know what's going on, and you're not seeing them move, for example, when she's quote quote turned off and let's say she can't get out of her chair, but she can't show you the emotion through her face, and if the voice is diminished, that's hard.
At what stage, kind of backing up a little bit, at what stage do you like to see a patient with Parkinson's come into you? Is this fairly advanced? Because I know Glenda's been working with Parkinson's for about 20 years now.
That's right. That's right.
So do you prefer to get folks right as they've been diagnosed to start working on the fundamentals, or are you more later stage?
And I'm really glad that you asked that, because with Parkinson's, a lot of times many people will say that one of the first things that they notice is that they just can't seem to get volume to their voice, or they notice it in their speech, and then they may go to their doctors and tell them so. And although they're audible and they're heard, it may not be so apparent, at that point. And what the research is showing from this LSVT program is that if we can get these people earlier, it doesn't cure it, but what it does is it helps to maintain the system at a level so that the point where they are then is that they are fairly loud and hopefully won't lose gain as the degenerative process continues.
I would think it'd be important, because you've heard of instances where people, not always with Parkinson's, but other disorders that may affect their speech, are interpreted as being drunk or under the influence of alcohol or some other drug, and police or other individuals will question them, and if they can't communicate what the problem is, then they could end up with some type of a situation that no one really wants to see.
And that's right. And then again, when you think of the Parkinson's with the masked facial expression and the inability to initiate, when someone says something to them, what is the first thing they think? Oh, they're not plugged in here. They're not, they didn't hear me, they don't understand me, or they're not choosing to communicate. And you can see how isolating that is.
One thing that really amazed me about this is these days when you think of therapy, you think of expensive machines, for example, or you think of a lot of equipment or this type of thing. And this is a people-driven product. If you don't have the good people, then you don't have something to help the patient with, because there aren't machines. You're not prying the jaw open. You're not working the tongue. This is the patient doing the work, and you got somebody guiding them along.
That's really how it works. And so much, again, when we talked about the calibration of the patient actually seeing what needs to be done, that's going to be so key in their success with the program. If they can really see the validity of what they're doing, and hopefully our job as therapists will be able to enlighten them and to show them the validity of it, that will make the program work much better for each of them. But you're right, I think it takes a special person that is able to relate that information to the patients, and the patient also has to be able to be receptive to it.
Now, what will you do with the data? I mean, each case obviously is going to be different, but you have two clinicians, in this case student clinicians actually, who are learning as each patient comes through, and then you have the data that you've collected. What happens to that? Does that become a part of a bigger picture?
Well, I have to first tell you that as I had told the students, that when you do the LSVT program, there's one of you usually. You usually do not have two clinicians working on this, so you can see how difficult it is where they're again facilitating and at the same time having to collect this data. So one person usually is the one that will do this. And then what we do with the data is we take daily averages of, you saw all those numbers that were listed out on that page. There's a lot of math in it, maybe not really complex math, but there's math in it. And then you take the averages, and then what we're trying to do is to see that over a period of time, hopefully from the time that we've done the pre-test to the time that we finished at the end of the 4 weeks, we're seeing a change. Now, there are parameters on that, because, for example, with speech, when we do the sentences, we don't want to go above 80 decibels because your normal speech is within 80 to 85 decibels. We don't want to go over 90 decibels when we're doing the ahs, because that's not natural for voices to do that. And so therefore, when you're starting to hit those levels, you're not going to see huge gains. But if we're able to, if we've gone from 70 decibels and we're now averaging in at 80, we've done a great job with that person. So that's what we look at.
That's a fine line. I mean, if you're talking about not getting too loud, you see two reasons. One, you don't want to hurt the patient. I mean, that can be a strain on the voice as well. But also, you know, shouting is, being loud is one thing and being understood, but shouting can cause you almost as many problems. If somebody's yelling at you, then they may not listen to what you have to say.
Right. And I think that that's where, as we were talking before, that we ask the patient, is this uncomfortable for you? Because there should be no pain, there should be no strain, and that we're looking for the clarity of that voice, and until we get that good quality, we don't continue on to stretch, you know, that volume until we're able to obtain that. And then another interesting aspect is with Parkinson's, the shouting, for example, if we're talking at a normal level, a Parkinson's person talking at our level is probably down here at a much diminished level. But to them, they feel like they're speaking the same as we are. So what we're asking them to do is to come up to a normal audible level. Well, to them, it sounds like they're screaming, like they're yelling. And so because with Parkinson's feedback, the ability for them to hear how they are sounding, that's very hard for them to do. That again is a product that we have to sell to them, that yes, although it feels like you're shouting, you're not. You've now reached an audible functional level.
That was one thing the students or the clinicians were doing, was setting that baseline. And I heard Glenda say that a couple times. Give me the, I think it was baseline is the term she used. Give me the baseline, and they would hit a note or they would hit a range at the certain loudness level, and then she would react to that and try and match that level.
Yeah, and I think that that's very interesting too, because again, with these patients, what makes this different than traditional therapies, we don't instruct them. As you notice, we have very few instructions. It's get loud, loud, get on top of your breath, get loud. And that's basically what our instructions are. So we don't tell them, you know, now take a deep breath and push your diaphragm. You know, we don't do that with them, because what has been shown in the research with the program is the more instructions you give, slow down your speech, breathe deeply, do this, it's not working. So if we keep the instruction very short and simple, then we're seeing these kind of results just simply by changing the voice, because it automatically seems to take care of the rate and takes care of the precision of the articulation.
And seeing results sounds like a great way to end our conversation. Jane Hostetler, thank you so much for coming by and sharing with us, and our thanks also to Glenda for allowing us to participate in this. And we're going to have to come back and visit with her and see how she's doing at some point in the future. But gee, thanks for coming by and sharing the information, especially about the Communications Disorders Clinic as well.
Thank you for having me.
Well, thanks so much for joining us also for Profiles. I'm Ed Highland. We'll see you next time.